Good evening, everyone. And today we'll be discussing the nutritional assessment of the surgical patient. Now, the important questions that we need to ask is why there's a need for nutritional assessment. You see a patient, you diagnose the patient, and you operate. Where does nutrition come into it? Secondly, we need to see what parameters we look at when we talk about nutritional assessment. Thirdly, do we do this assessment for all patients, or we select a few patients, and what are the criteria for which which we select these patients? And lastly, the timing. When do we assess these patients? Do we assess them the moment we see them in the OPD, or do we assess them after admission? And what kind of treatment are we giving these patients? So these are the questions that we are trying to answer today. And the last is how to treat these nutritional problems. So when it comes to nutrition, the important thing is that food and nutrients are only one part of it. The other aspects of nutrition are the mechanisms of ingestion, processing, and excretion of these food and nutrients. And the third aspect is the patient's general lifestyle, his health, and the changes in his physiology during the disease. So all three are interlinked, and that is the sum total of what we call the nutrition of the patient. And it is not just the nutrients that the patient ingests. So nutritional disorders they have various types. These are the major classifications of nutritional disorders. You have malnutrition, you have sarcopenia and frailty. On the other spectrum, you have overweight and obesity. You have solitary micronutrient abnormalities, and then you have refeeding syndrome. But for the purpose of this talk, and mostly because these two are the most commonly encountered problems, we are going to be dealing with malnutrition and sarcopenia and frailty, because these are the patients that we generally see in our OPD, unless of course you are running a bariatric OPD. So malnutrition or undernutrition, it is classified again into disease-related malnutrition with inflammation and disease-related malnutrition without inflammation. And the third category is malnutrition without presence of a disease. So all of them have different mechanisms of affecting the body's physiology, and we won't be going into the details of that. But the most important part of this is, and the term that all of us must know, is cancer cachexia, because this is what we usually see in our outpatient departments. Whether you are an oncologist or you're an oncosurgeon, whether you are a GI surgeon, you are a general surgeon, you are going to see cancer patients who come in with their bones showing up, with their pot bellies, and these patients categorically fit into the term cancer cachexia. So malnutrition is defined as BMI less than 18.5 or 10% weight loss with BMI less than 20, or fat-free mass index less than 15, which is of course slightly higher for females, because females generally tend to have a little bit more of fat percentage in their body. Sarcopenia and frailty, on the face of it, they may appear to be similar terms, but sarcopenia is reduction in the muscle mass with muscle strength and physical performance that also gets affected. Whereas frailty is irreversible reduction in the endurance and physiologic function due to age-related changes. So sarcopenia is more disease-related. Sarcopenia is easier to assess using grip strength and gait speed, and sarcopenia is reversible. Frailty, on the other hand, is majorly due to age, and it leads to an overall reduction in the patient's physical strength, and that is irreversible. Cachexia is again, it's reversible, it is treatable, and is usually due to a chronic disease. So how does malnutrition impact you as a surgeon? So lack of intake or lack of uptake of nutrients due to various diseases leads to altered body composition. Most commonly, your protein levels will go down, your fat percentage will go down, and your skeletal mass will be the major component of your weight. So this leads to diminished physical as well as diminished mental function. and this leads to impaired clinical outcomes from the disease itself. And these patients categorically are poor candidates for the stress of surgery. So why is there stress during surgery? So surgery, a surgical insert, has three phases. The first two phases are the catabolic phases, the ebb phase and the flow phase. The ebb phase is where there is decrease in the metabolism. It lasts typically only for the first 24 to 36 hours. Next is the flow phase when the body decides that, okay, now is the time to start doing something. And that is where it increases the metabolic rate in a hope to recuperate from the surgical insult. But unfortunately, the nutrition does not catch up till this time. And that is why, in spite of it being the flow phase, in spite of increase in metabolism rate, the overall body remains in a catabolic phase. And this lasts for up to 10 to 12 days. Now, this is when nutritional rehabilitation kicks in. And for the next around 4 to 6 weeks or maybe 8 weeks, the body takes nutrients, assimilates them, stores them, and replacement of lost tissues is how the body manages to come out of the surgical insert. So a neuroendocrine stress response is categorized by all of these things. There is increased resting energy expenditure, there is proteolysis, there is negative nitrogen balance, there is fluid retention, there is mobilization of glucose from all parts of body, like gluconeogenesis. So this is how the body will respond to a surgical stress that, okay, you've asked me to do something, fine, let me do something much more than is required. Now, where does nutrition come into all of it? When you replenish the nutrients in a surgical patient, it reduces the cortisol, it reduces the glucagon, and in short, it reduces the catabolic activity of the body. It shortens the ebb and flow phases and leads to early induction of the anabolic phase. The negative nitrogen balance is reversed, the protein stores are replenished earlier, and cachexia is prevented. So tissue healing, as we all know, proteins are required for tissue healing. So once you reverse the negative nitrogen balance, tissue healing improves, that leads to faster recovery and better outcomes. So if you want your patients to do well after surgery, you must take care of their nutritional needs before the surgery and not just start a bag of TPN after surgery. So how do you assess which patients will need this nutritional therapy prior to surgery? These are the basic ways of assessing. You have anthropometry, weight, height, BMI. Then you have slightly specialized but still anthropometric measures like mid-arm circumference, waist circumference, skin fold thickness. The problems, the clinical examination includes the fat cover, skin turgor, rounded contours, hair, nail, teeth examination, pallor, pedal edema, ascites. There are a few biochemical parameters like hemoglobin, albumin, prealbumin, retinol binding protein. But the problem with all of these anthropologic measures and the clinical and biochemical measures is that they are subjective. Most of them are non-measurable. There may be inter-observer error. There may be a bias. The measurements may be inaccurate. The yield is low, and they may be non-reproducible due to lack of equipment. So overall, these parameters of anthropology, of anthropometry, and clinical and biochemical uh, parts are not entirely reliable for assessment of the patient's surgical nutrition. So then you have subjective global assessment, where you evaluate the patient's history, where you examine the patient, and accordingly you grade the patient into three categories, that is well nourished, moderately malnourished, or severely malnourished. The history includes the changes that is caused by the disease, and the examination includes the physical changes that is brought on by the disease. Another way is nutritional risk screening, and there are all of these components in nutritional risk screening, and the total of it is 14. So a total score of 14 indicates a very low nutritional risk. Okay. So when you then again you can go in with lean tissue imaging like DEXA scan, MRI, a CT scan at the L3 level to see the thickness of the psoas muscles. You can do USG for a bioacoustic impedance analysis, and you can calculate the lean tissue strength. You can calculate the fat-free mass. You can do a DEXA scan to see the skeletal mass of the patient. But then finally, all of these are an overkill. And a simple clinical subjective global assessment or a nutritional risk scoring is enough to assess the patient whether the patient is well nourished, moderately malnourished, or severely malnourished. So, which patients should undergo nutritional screening? Ideally, of course, all patients should undergo nutritional screening, but that is not cost effective. A patient comes in, a young patient in their late 20s or early 30s, he has a indirect inguinal hernia. So it is very unlikely that this is a patient who is malnourished and will require nutritional rehabilitation. So when talking of nutritional screening and nutritional rehabilitation, the cost effectiveness is definitely a factor that will come into play. And so ESPEN, the European Nutritional Society, has come up with a few criteria where nutritional screening is recommended. So which are these patients? Those with BMI less than 20.5, those with a significant weight loss, those with diminished food intake, and those with severe or chronic disease. So nutritional therapy, also known as nutritional support or nutritional rehabilitation. So how do you do it? So if you provide nutrition via any route, be it oral, enteral, parenteral, then the types of diet that are used in providing this nutrition can be a regular diet, a fortified diet, targeted nutrition, micronutrient supplement, and lastly, immunonutrition, which we'll come to later. So the criteria to initiate nutritional support are that patients who are at severe nutritional risk, you calculate the NRS and SGA, and patients who are at severe nutritional risk are those who have at least one of the following: either a significant weight loss within the last 6 months, the BMI is less than 18.5, a subjective global assessment grade C, that is severely malnourished, a nutritional risk score more than 5, a pre-op albumin less than 3, and a serum transferrin less than 200. And both these are, of course, without any hepatic or renal dysfunction. So these are the patients who are at severe nutritional risk, and they should receive nutritional support and nutritional rehabilitation prior to the surgical intervention. Again, you go into the past medical history, whether there's any chronic disease, you select elderly patients with sarcopenia, you select patients who are undergoing major abdominal surgery, and you predict that if a patient is probably not going to be able to eat for 5 days perioperatively, say you are doing a total esophagectomy, say you are doing a total gastrectomy, these patients will probably not eat for the first 5 days after surgery. Or if the patients are unable to maintain more than 50% of recommended intake orally for more than 7 days, as per your anticipation. Again, surgeries like Whipple's procedure, surgeries like distal gastrectomies, where the intake will begin early, but it will be slow and inadequate. So these are the patients in whom you have to initiate nutritional support. So when do you start nutritional support? Ideally, NRS or SGA is to be done on admission or during the first contact. You observe and document the oral intake. You regularly follow up the weight and BMI. If there are historical records available of weight and BMI, then you should use them. You should counsel these patients regarding their nutrition, regarding taking high protein diet, regarding changing their diet and lifestyle. And as soon as the risk is apparent, you should institute nutritional therapy. And also, you should avoid factors that promote catabolism. What are these factors? Long perioperative fasting. In the olden days, we used to keep the patients fasting overnight. Morning 9 o'clock, you have a surgery, the patients are fasting since 10 p.m. the previous night. So, this 10 to 12 hours of fasting pushes the patient into a catabolic phase preoperatively. and that results in poor nutritional outcomes and poor surgical outcomes after the surgical intervention. Ventilator support and paralytic agents. A lot of surgeons, especially those with major thoracic surgeries, long abdominal surgeries, choose to electively ventilate patients overnight after the surgery. The problem with that is that this promotes catabolism, this promotes protein breakdown, and the recovery of the patient is delayed. Again, delayed oral feeds. The more you keep the patient fasting after the surgery, the more catabolic reaction you expect from the body, and the body takes longer to heal. And long-term immobilization. So, as part of ERAS, as part of enhanced recovery after surgery, we discourage all of these. We encourage that the patient should be fasting for only 4 hours prior to surgery, 4 hours of liquids, that is. We encourage that the patient should receive glucose-rich fluid 8 hours and 2 hours prior to surgery. We encourage early oral feeding 12 to 36 hours after surgery. We encourage early mobilization within 12 hours of surgery. So these ERAS protocols have mainly come into play to reduce the catabolism and reduce the surgical stress that the body goes through. So clear liquids up to 2 hours before anesthesia is fine. Solids, yes, you need 6 hours. Clear liquids, only 2 hours fasting is enough. Nutrition should be instituted within 24 to 48 hours, and in some cases within 12 hours also after the surgery. Solid organ transplant patients should receive nutrition within 24 hours, bariatric surgery within 24 hours, and patients with severe nutritional risk that is calculated before the surgery should receive nutrition therapy for 7 to 14 days preoperatively. If the surgery is not urgent and the patient is cachexic, then it may be worthwhile to defer the surgery by 14 days for nutritional buildup of the patient. And we have done this with early cancers or with benign diseases where the patient is very cachexic. You put in a nasovaginal tube or you put in a feeding jejunostomy tube and you nutritionally build up the patient, defer the surgery by 2 weeks. And when the patient is doing better nutritionally, that is the time when you intervene. So in hemodynamically unstable patients, if the patient is resuscitated well and is stabilized on declining doses of less than 2 vasopressors, you can start enteral feeds post-operatively. If the patient is on vasopressors, then even you can start within 24 to 48 hours. And if the patient is in persistent shock, that is the only time when early enteral nutrition should be avoided. That is because in persistent shock, especially septic shock, the gut blood supply would not be adequate, and that would lead to complications like ileus and bloating and subacute obstructions. So in these patients, early enteral nutrition should be avoided if possible. So how to estimate the energy and protein requirements? There are routine formulae. You take the resting energy expenditure and you add the protein requirement, you add the energy requirement, and the best survivals are achieved when the calorie intake of at least 80% of the required target is achieved by oral therapy. If not, then you have to supplement it by parenteral therapy. For obese patients, the energy requirements are higher, the protein requirements are higher, and they will change with rising BMI. So these are the various modalities of providing nutrition. When it comes to nutrition, the most important and the most satisfactory treatment, most satisfactory modality of nutrition is oral route. You can feed the patient orally and nothing like it. The patient will be happy, he'll bless you. But if that is not feasible, then you have enteral feeds and you have parenteral feeds. For enteral feeds, you have the nasogastric tube, you have the nasovaginal tube, you have the feeding jejunostomy tube, you have the percutaneous endoscopic gastrostomy tube. So these are the enteral feeding techniques. If for any reason you are not able to feed the patient enterally, then parenterally you need either a peripheral line or a central line to start feeding the patient. So how do you assess which patients will need enteral nutrition, which patients will need parenteral nutrition? So the most important thing is that unless and until there is a contraindication to enteral nutrition, you must start enteral nutrition. What are the contraindications? If the patient has intestinal obstruction, if the patient has ileus, peritonitis, frank or impending bowel ischemia, intractable vomiting, diarrhea, these are the patients in whom enteral nutrition may be contraindicated, and you may have to institute parenteral nutrition early. Second thing is the tolerance to feeding. If the patient is not able to tolerate the oral feeds, that is another scenario where you may have to either supplement or shift completely to parenteral nutrition. Now, you anticipate the need for duration of parenteral nutrition. If it is long term, then a centrally placed catheter is definitely preferred. If it is short term, then you can go ahead with a peripheral parenteral nutrition. If you start off with parenteral nutrition, but the oral nutrition improves and becomes adequate, then you advance and shift to complete oral feeding. So the gist of this flowchart is that as long as you can feed the patient enterally, feed the patient enterally, and if you can't feed the patient via the GI tract, then you think of parenteral nutrition but as a supplement and not as a blanket switching to parenteral nutrition. So, what is immunonutrition? It's an upcoming topic, and it is frequently asked in exams. In fact, the patients might also ask you about immunonutrition. So, with immunonutrition, you try to modulate the immune activity and the consequences of immune system activation using specific nutrients in amounts above that encountered in the diet. You have certain RDA, recommended dietary allowance. So some diets will have some of these components in a small amounts, but the whole idea of immunonutrition is to supplement it with more and more of these nutrients so as to modulate the immune system, reduce the post-operative inflammatory response, and have better outcomes. Most important of these are the omega-3 and omega-6 fatty acids, glutamine-rich diets, and antioxidants. Again, the data on this is not very clear. There are few studies that do state an advantage of using immunonutrition, but it cannot be extrapolated to all patients and all diseases. So, immunonutrition should be again used in a selected group of patients who might benefit from it. Now, the main mechanism of action of these is the reduction in eicosanoids, increasing T lymphocyte functions. So this is how they modulate the immune system. So the final message of this entire talk is first that integration of nutrition in patient management and patient evaluation is definitely mandatory. If not for all patients, you should do it for a wide selection of patients. The nutritional therapy should start early and pre-operatively, not post-operatively. The catabolic phase, as long as you can reduce the catabolic phase, your outcomes would be better. And lastly, targeted patient-specific nutritional therapy is always going to give better results than giving blanket supplements to all patients. So how do you approach this all theory? How do you actually approach a patient? So when you see a patient in OPD, they have significant weight loss, they have diminished food intake, you examine the patient, you calculate their BMI, you calculate their anthropometry, and if they have muscle wasting, peripheral edema, low BMI, then you screen with albumin or pre-albumin and transfer. Once the screening is complete and you see that this patient has a severe risk using SGA or NRS, that is the time when you institute nutritional therapy using personalized macronutrient and micronutrient based therapy. Now, a case in point is these are two patients. One is the gentleman on the left side is 81 years old. The one on the right is 84 years old. Both underwent Whipples roughly 3 days apart, and both of them were discharged on post-op day 8 and 9. And while it may seem miraculous to the patients themselves, because generally for such major surgeries, we estimate a stay of say 12 days, 14 days for such elderly patients. But the most important part of their treatment, I mean, of course, surgery and post-operative recovery is uh, one of the most important parts. But equally important is the pre-operative assessment of nutrition and pre-operative nutritional rehabilitation. So with these elderly patients, with these nutritionally compromised patients, if you give them a little time, if you give them a little uh, assessment and evaluation to assess their nutrition, and you give them a chance to recuperate from the surgery early on, then the outcomes are much better.